How we pick a technology for the SFA is really complex because there's a lot of variables that play into this. How big's the vessel? How long's the blockage? Probably the most critical one is how much calcium's there. But in all those kind of things, other than for a few niche blockages, most of what we're doing is drug-based, whether it be a drug-coated balloon or a drug-coated stent. And that's the way it's going to be because cardiology has already led us this way with lots of data in a different vascular bed, but the pathology, the physiology, the chemistry is all going to be the same. So how I decide between a drug-coated balloon, drug-coated stent, first off, there's no randomized trials to say one is best. We do have at least a look at things down in the future, and that is drug-coated stents right now have the longest 5-year data, and it's very good. Drug-coated balloons just came out with 5-year data, so we don't really have all the look that we've had with drug-coated stents. There's a population that we don't like to leave a prosthetic device in. Very active individuals, patients that have really long blockages because our current stents and really long lesion lengths don't allow for enough compliance to the vessel. There's another population that you just say, I don't want to leave a prosthetic in, so some of it can be patient decision. But in these very fibrousy, more moderate calcified lesions that you're not going to get a good balloon result, or if you go to try to get a balloon result and you have to use something because it's not working, then you can use a drug-coated stent or a stent. So until we have randomized controlled data between drug-coated balloons and drug-coated stents, we're not going to know exactly which blockage may be the best for which technology, and our time frames are changing too. So we really need trial data. So it really should be playing a large role. I have to give a talk here about cilostazol as well. It's a generic drug. And 40% of the population, it doubles their walking distance. We should be using it more than we do. We're starting to get information on the DOAC usage with antiplatelet therapy, so our best medical therapy is changing. It's not really adding to our claudication patients, but it's helping to decrease repeat procedures and making the incidence of more blockage go down. So it's all a changing environment, but medical therapy is always going to be the cornerstone for this. Why in the periphery do we use paclitaxel, and in the coronaries we use limus drugs? Our history lesson says we started with paclitaxel in the coronaries. The therapeutic window is pretty small with paclitaxel, so we don't have as much freeway to get around things. As we're using more and more technology, we have to be really careful that the paclitaxel doesn't have an adverse effect that we may not recognize. That's why studies are so important. If you said all things are equal, we would like to get limus. It has a larger therapeutic window into the periphery, but we're still waiting on how to really effectively do that because so far it hasn't worked.